this therapy for several years. Have placed over 150 of the devices, and so I have a pretty good experience with the therapy and what it takes going into it and afterwards. I don't have any disclosures relative to this therapy or this treatment. The things that I wanted to specifically comment on in the LCD as it's written, the first thing is the way that it is worded for the sleep endoscopy training. Sleep endoscopy is an absolutely critical part of determining the correct patients for Inspire or hypoglossal nerve stimulator therapy, and the wording of using a second opinion service for validation of at least 80% agreement in 15 consecutive studies was what had me a little confused or just concerned of the way that it's worded for a few reasons. I put something there at the bottom that is, hopefully captures the points I'll make on the next slide. And so if we can go on to that next slide, the things that made me think it would be better worded in a different way is that as it relates to candidacy for a hypoglossal nerve stimulator, I feel like there should really be 100% agreement between the surgeon implanting and any representative from the manufacturer as to whether or not they would be a good candidate for that therapy. Not necessarily every little point of the endoscopy, but certainly that particular issue. And so I felt like eliminating the 80% wording would be, ideal, in my opinion, for that reason. I also felt like it made it a little unclear as to what that meant and how that requirement could be satisfied. I wasn't sure if the patients needed to be Medicare patients or any patients, or even if they needed to be the particular provider's patients, and who would track this information. And then what would happen in the event that somebody failed to reach the 80% benchmark? Would they just repeat it, or how that would work? And then the last point on there is that I think, as I mentioned, that a sleep endoscopy is absolutely critical, but I think that the requirement or that wording is maybe unnecessary because, if you look at all of the data that's out there, as I'm sure many of you have, it's consistently shown to be fairly effective, and that is a sign that the correct patients are being picked with sleep endoscopy as a result of the training that's already done in order to even begin a program of implanting this device. And so I think it's already currently built into the training for an implanting surgeon, and perhaps just expanding that and then being approved as far as somebody who knows that step, which is just essentially another step in the procedure. It's just before the actual implantation starts. So those were the concerns that I had, and I felt like for those things, switching it over to saying that certification from the original training program, and then potentially if it was worthwhile to have second opinion, which is probably done in most instances for the first 5 or 10 anyway, but something along those lines to minimize the confusion about an 80% agreement and that sort of thing. The next point for discussion that I saw was as it related to the wording around the initial consultation. I felt like, as it said, excluding just routine post-op care, that the consultation, post-implant evaluation, and other issues should be performed strictly by a sleep physician, and I'm not sure that that's necessary. There are certainly some implanting surgeons who are also sleep certified, others who are not, and that work with a sleep physician. And there are, for example, that's how it is at my program, and we work pretty well hand in hand. Some of the things they have me to do, and others, certainly as it relates to an overnight sleep study, they're going to do. And so I feel like adding, a qualified implanting surgeon, to do the parts of it that are appropriate, certainly not, interpreting polysomnography, but adding that to the wording as it is would be beneficial. And then also, as it relates to the initial consultation, is that their sleep study, or is that a separate visit after a sleep study? And what exactly would qualify for the initial consultation prior to seeing surgery? Because I think if all of the criteria are met and documented, whether that's by the implanting surgeon or the sleep medicine physician, it should be comparable and would essentially, eliminate the chance for duplicating the work and or the expense to Medicare or the patient by having to see, two people. And also I feel like there's not a lot of other specific sleep policies that have that same type of wording in there, but at the same time, the sleep physicians are going to be, by default, part of the management of a sleep apnea patient. On the next slide, similar to what I just covered in that some of the language for the shared decision-making as to whether or not that had to be their sleep medicine provider, or could it be, a licensed physician or simply, the implanting surgeon? Because if a patient has had clear CFAP failure and meets all of the criteria, and we see that, then I don't know what the value would be for them seeing, a sleep medicine physician to say, yes, this is in fact the case, and then coming back to an implanting surgeon, or why it would have to be, strictly that one type of provider and not anyone on the team managing those patients. Those were the main points I wanted to raise for discussion, and I'd be glad to hear any questions about that or any other points that have been discussed earlier.